welcome to today's Respiratory Matters webinar, and thank you for joining us. I'm Andrea Pace, the Assistant Network Manager for Respiratory Conditions at NHS Wales Performance and Improvement, and it's really great to see you today, and thank you for joining us. These webinars are about bringing colleagues together, sharing practical learning and supporting the improvement across respiratory services in Wales. Whether you join us regularly or this is your first time, we hope that today's session will be of value to you. So before we get started, just a few housekeeping points. Please keep your microphones muted and your cameras switched off during the session. Today's webinar is being recorded and will be shared on the Respiratory Matters Teams channel and our network website shortly after the session. If there are any questions as we go along, please include them in the chat. We'll keep an eye on those and come back to them during the Q&A at the end. If we don't manage to get through everyone's questions today, we'll follow up afterwards with responses to any remaining questions. And just a reminder, we do issue certificates of attendance for people here at the live session. And if you'd like a certificate, please let us know and put it in the chat bar before the session ends. Unfortunately, we're unable to issue certificates for people watching the recording as we can only verify attendance on the day. So, moving on swiftly, introducing today's session. It's focused on improving COPD pathways with the All Wales COPE template, and the acronym is for Create Once, Publish Everywhere. This is a real practical session looking at the All Wales template, a standardised clinical tool designed to support more consistent, high quality COPD reviews across primary and community care. Over the next hour, we'll explore why the national template was developed, how it supports better assessments and consistency, and the benefit it brings for both clinicians and patients. We'll also hear some early insights from implementation across participating practices. So I'm very pleased to have two great speakers join us today. Professor Keir Lewis, the Clinical Respiratory Lead at Hywel Dda and Professor of Medicine at Swansea Uni. Keir's clinical research interest includes COPD, smoking cessation and chronic respiratory failure, and he's been developing and refining the COPE template since 2020. Also, Natalie James, who is the lead nurse for the Respiratory Network, is an advanced nurse practitioner and non-medical prescriber and head of education for clinical and remote care at WAST. So, welcome Keir and Natalie, and thank you for taking the time to be with us today. I'm handing over to you.
Sako, would you like me to share the presentation?
Oh, I just shared it. It doesn't show on the screen, sorry. Kristen, if you don't mind, yes, please, sorry. Isn't working on my Teams.
Sec.
It wouldn't be a webinar with a bit of IT problems. Thank you.
Here we are. Hopefully that's come up. And
Yeah,
just let me know, Natalie, when you...
Yeah, I can see the slides. Just checking if Keir is here to start the session off. Keir, are you with us? I don't think Keir is with us. So what I will do, you'll have to bear with me because I can make a start on his slides.
Okay.
If that's okay.
Come in, Christina, can you put it on presentation mode because we can just, you know, it's not on the full screen.
Is that better?
That's it. Thank you.
Okay.
I'll make a start then. You'll have to bear with me, obviously, because I'm going to be going through Kia's slides. If he does join us, then I'm sure he will take over from where I am. So as I've just been stated, really, my name is Natalie James. I'm currently in a brand new position as Head of Education in the Welsh Ambulance Service, and I also lead on the respiratory network for nursing for Wales. And Professor who will hopefully join us soon is the clinical respiratory lead in Hywel Dda, and between us and many others who may be on the call today, we've come together to look at and develop a COPD template for primary care. Next slide, please. Next slide, please. So we're going to discuss a little bit about the background, the feasibility of the project, and we're also going to discuss some next steps, so where we are and where we'd like to be for the future. Next slide, please. So as we all know, when we're conducting any healthcare professional review, there's key opponents to an annual review. It's really important that we take into consideration, you know, the patient information, the demographics, past medical history, medication, allergies, presenting complaint. And then hopefully with all the information that we gather together, we then lead on to, with further investigation, tests, chest x-rays, spirometry, a diagnosis. We then go on to possibly prescribing pharmacological treatments such as medication, and taking into consideration sort of any specific allergies that the patient may have. Considering any care goals, so it's really important that we work in partnership with our patients on an agreed self-management plan and treatment, so that we can ensure that interventions and actions and follow-up are undertaken. Next slide, please. So to help primary care deliver remote review optimization in relation to COPD, many of you might have already seen this pyramid that we use quite regular within respiratory management. So we need to ensure that we sort of optimize treatment, make sure that we confirm and make sure we've got an accurate diagnosis. But some key interventions which are non-pharmacological are also really, really important. And this is smoker cessation interventions, so referring patients to our All Wales smoker cessation services, ensuring that patients have vaccinations according to their criteria, are referred to pulmonary rehab. And I know across Wales at the moment we are struggling in some areas to perform pulmonary rehab due to funding, costing and staffing, and this is an area that we're currently reviewing. But as part of this template, we would encourage everybody to press that button to refer to pulmonary rehab, so that we can audit the amount of referrals that should be undertaken across Wales, so then we can put the necessary precautions funding streams in place to support our rehab services. And also we've got across many localities, across many health boards, the importance of the expert patient programme. So patients with expert knowledge within respiratory, whether it's COPD, asthma, bronchiectasis, etc. And these programmes are run independently and sometimes supported through Asthma and Lung UK. Ensuring that pharmacological management is appropriate, you know, stepping down treatment where appropriate, reducing the amount of inhalers and ensuring that one device is possibly used, and ensuring that, you know, we think about the carbon agenda and the carbon footprint. So these key things we need to ensure that it is part of our sort of clinical assessment and review. Next slide, please. So to start off the project, a few people got together in Hywel Dda, and this project happened in COVID, where face-to-face consultations couldn't be undertaken for obvious reasons, and some of the way that we started moving or shifting our work was into remote care. So Hywel Dda, and the names that might be relevant or of, which are listed there, started looking at development of a template or a checklist in relation to consulting patients over telephone triage. Next slide, please. So the way they've done this is that they developed this checklist, and it was tested in Tenby throughout 2020. There was actually a pilot which was undertaken over that period, and it involved these 3 practices. So it was T Ely practice, Tenby practice, and Bro Peda medical group. Really powerful intervention with lots of engagement really from the GP practice teams. And one of the key targeted interventions was identifying patients on multiple inhalers and possibly, our current smokers. And all the reviews were done via either Consultant Connect or Tend Anyway, via phone or team. And all the team meetings which were undertaken were also conducted virtually. Next slide, please. So this is the number of practices. So there was the 3 practices, and this baseline data shows the list size, the number of COPD patients registered, but the number of patients reviewed. And out of those patients, 157 were reviewed, but 31% of these patients had uncertainty in relation to their diagnostic history. Next slide, please.
Can I just stop you there 1 sec, Natalie? This is really important. Sorry, I come in a bit late.
That's okay, no problem.
If we go back that 1 slide. So of the 157, a couple of things here. We managed to get 157 done in just 2 weeks. So we would have completed the whole COPD register of 869 within 10, 12 weeks. It's feasible. Like, we can go for a lot of people very quickly using this template. So a big proportion. By 31% diagnostic uncertainty means they were on the COPD database, but their lung function wasn't consistent with COPD. It was just incorrect somewhere. And then so that fits with all the audits that at least around a third of spirometry is not consistent with COPD. Is either normal or it's restrictive. It could be COPD and something else, so we had to look at 1 in 3 patients we weren't even sure had COPD, which means a lot of unnecessary work, possibly. Sorry to interrupt.
Fine, you can carry on now, Kia.
Oh, fine, I'm sorry. Yeah. So I'll pass over. So again, this intervention. Let's just look at the bottom slide of those 157 patients. 53% we changed guidelines, we changed treatments, so more than half just with a simple telephone template. More than half those patients we changed things to be consistent with the Welsh and BTS guidelines. So even if you did have confirmed COPD, around more than half were not on optimal treatments, let alone being referred to other conditions. They weren't on the right combination of inhalers mainly. And in that first 157 patients, on average, some slightly went up, but on average we saved around £3,000 per practice per year, just on that first little bit. So we improved treatments, we showed it was feasible, we could get for a lot of people just over the phone, and we saved the practices money. And that was in a time where we weren't allowed to actually reduce inhaled steroids in COPD because of COVID. So it would have been more cost savings if we'd have followed it in normal times. So it actually saves money. The biggest change was at least 1 in 5. We removed multiple inhalers to a single inhaler, and that saved money. And also we increased referrals for vaccines, pulmonary rehab, expert patient program. It all went up just because it was reminding people to do the basics. And it saves money. Okay, next. So we published on this, we put it through peer review, we showed it was feasible, it was safe. Only of the 84 changes we did on that first 150 patients, Only 4 were reverted back where the patients wanted to go back to their normal inhalers or their previous inhalers. They didn't like the new inhalers that we recommended. But that was, I mean, 80 of the changes, vast majority, were maintained. No one was harmed. The diagnostic accuracy is important because that comes through spirometry at scale. So at least 1 in 3 were, it's like saying you've got diabetes, but you've had a normal blood sugar, HbA1c. We need to conform to those standards. And again, the biggest thing, we improved the non-pharmacological inputs and referred people, but we also optimized medicines over the phone, basically, very quickly. Next slide. And then I'll hand back to Natalie, who knows more than me about this bit.
Okay, so there's many issues in relation to the COPD templates that we use across primary care. As you all know, there were 2 separate versions. So there was EMIS and there was Vision. We are switching, as you're all aware, from Vision to EMIS at the moment, and across each practice as well, especially within my own health board, which was an Iron Bevan Health Board. Different templates were used locally, but also different templates for review were used across Wales. The other issues were highlighted that some of the management guidelines, and this is across all differential diagnosis really and other conditions, but you know, from a COPD perspective, the All Wales management guidelines weren't embedded within the system. So this caused concerns or issues regarding accessing the guidelines and the data. Referral documents were also not embedded, so there was issues regarding PR and smoker cessation. So again, taking more time to access these referral forms. Throughout templates, red flags were not alerted, so that there was areas that you didn't discuss, didn't cover, didn't highlight, for example, exacerbations or hospital admissions. Again, this wouldn't red flag. There was lots of codes as well for specific interventions such as spirometry. Unfortunately, within our health board, I did a review, and over 50% of the practices were incorrectly coding their spirometry, so it wasn't pulled off then through the NRAP reports that we all get. And you know, some of these templates take so much time, and this was from feedback from our general practice nurses within practice, because some of the templates contain too much information, and information that wasn't necessarily needed for that review. Next slide. Okay, I think it's back to you now, Kia.
So thank you. So Natalie tweaked it, and then we wanted to try and reset it out. And this is really trying to build on an electronic template. We had a joint working arrangement with AstraZeneca, and we pushed this through something called a TriTac, where we evaluated the impact. So we wanted to just roll this out at scale, see if it's feasible at scale, not just across 3 rural practices in Hywel Dda, and also not just look at cost savings over the first year, but look at the impact on patients. Are we actually going to be able to refer people to pulmonary rehab, etc., without coming out of the template, direct clicks, and can we even get them to pulmonary rehab? You know, it does shine a light on some of the other core parts of COPD treatment are suboptimal in Wales. But if we can refer people in and track them, that's a good thing to do. This is what the cardiologists, the lung cancer doctors, the oncologists, everybody else, the diabetologists are doing, and respiratory has to get better at doing. We're not good enough at following outcomes after referral. So can we show an improvement? Next slide, please. This was done at scale, and I'm really grateful. This is where Natalie really and a team took on board, and all you guys that worked in the primary care practices. There was 3 in Hywel Dda, around the Llanelli cluster area, and mainly in Iron Bevan, and then Iron Bevan led at scale. And we wanted to put it across at least 3 or 4 different health boards to see, can it adapt? It's in primary care, it's on EMIS, it's on Vision. It should be massively and quickly scalable. Next slide. Do you want to talk about this?
Over to me. Next slide, please. Okay, so as Kiev said, the project started off quite a few years ago within Hywel Dda. But the project or the template has been discussed for many years. I think everybody's had discussions around the idea of having an always template, something that is easy accessible with integrated referral forms and things like that. And myself and a couple of other respiratory nurse specialists from across Wales back probably 8-10 years ago started looking at the development of a COPD and asthma template. And we started embedding it within an Iron Bevan Health Board and CUMTAF, but unfortunately at that time, due to many reasons, financial reasons as well, it was never sort of spread and scaled across and developed any further. My background is very varied. I worked in acute services for 17 years and in primary and community care for the past sort of 10 years. And whilst I was working as a specialist nurse within an acute sector, we would complete obviously a thorough respiratory assessment and review, and we used template letters. And what I identified is that although that patient had come and had a full review with spirometry and everything, they were then being called into their GP practice, you know, as part of their annual review. And after discussion with practice managers, GPs and practice nurses, this was due to the fact that the navigators or your admin within your GP practices would receive the letter, but because the letter wasn't coded, the letter was just uploaded into the system. But if the letter was coded, they could then code their system to prevent duplication really of work. So the template was also used then as a letter of communication, but it was also used for an educational programme. So whilst working in primary community care, we developed a 3-day academy course, and the primary care team also completed some mentorship and training across an Iron Bevan Health Board to support new general practice nurses or general practice nurses who didn't have sort of respiratory knowledge. And the practice nurses felt that this template also supported them within their consultation. So it was a paper template originally. And this is something we embedded into our 3-day academy course training to try and improve the uptake and the completion of a full basic respiratory review. Not only did we design templates for asthma and COPD, but we also developed templates for bronchiectasis. And one of the reasons for this, as I've said, is to ensure that we've got accurate clinical coding so that we use the most appropriate codings when needed. Next slide, please. So this just demonstrates the letter which was sent out from AB. As you can see, it's quite a detailed letter. Now, this one was actually a general respiratory paper template, which included respiratory diagnosis such as COPD, asthma, bronchiectasis, ILD, heart failure. So this one is a very detailed template, but this is the template we used in acute, and then we amended it slightly to use in primary care. Next slide, please. But as you can see, everything is coded where needed. So the admin team or the general practice nurse, whoever was reviewing that patient, could upload the assessments into their clinical system to say it'd been done. Another key thing on here is through COVID, it was really difficult to identify patients with non-invasive ventilation within the system as well. So again, not all patients who are on NIV are coded within the GP practice, but we hope that with the All Wales Oxygen guidelines now and the All Wales work streams and the All Wales Oxygen referral form, then oxygen is coded within general practice. Next slide, please. And next slide. So I'm not going to show you the video today, but an educational video was developed then as part of our rollout of our programme, because we worked really closely with pharmaceutical companies, AstraZeneca, and and as an All Wales group, and Kia was the lead on something called ACT, which was a sort of research programme, and several projects were submitted to the ACT in relation to respiratory conditions. And then out of the 6 projects which were sent forward, the COPE, which is COPD optimising pilot project, was the project supported to develop further, and the reason being for the many reasons that I've already just highlighted and discussed. So next slide, please. So as part of that, a educational platform was also set up with training videos in Vision and in EMIS, and this is something which helped support us in relation to rolling out the training and education delivery across Wales. So this was the first draft of the EMIS template. We're currently working on a second draft, and as you can see, it's quite simplistic, easy to read. As you can see, it's again, it highlights in red, and it red flags when things need to be acted on. So example, if a eosinophil level is over 0.3, then this patient may have other cofactors and may need to be considered for inhaled steroids, or if the spirometry ratio post bronchodilator is above 0.7, then again we need to think about our differential diagnosis. The next part is in relation to smoking status. So again, recording if patients smoke, if they're ex-smokers, what they smoke, when they smoke, how many they smoke, and obviously linked in with the PACU history as well. And when I talked about referral forms earlier on, then the plan is to integrate the Smokers Association or Wales referral form so that it auto-populates and is sent directly to the service, because we all know the amount of time we take filling in referral forms, which can be very, very time consuming. Next slide, please. So again, the template talks about MRC, and if the MRC is 3 and above, then it populates a template for a pulmonary rehab referral form. Now, obviously in this one I've highlighted the Aneurin Bevan Health Board referral template, but across Wales, again, different templates are used, but as part of the network and the pulmonary rehab group, an All Wales pulmonary rehab template is currently being developed, and I'm hoping to see the final copy of this within the next 2 to 3 weeks so that we can integrate it within the COPE template. It also calculates your CAT score. Again, the COPD assessment tool, so we can flag up if things are improving or deteriorating. Oxygen again, the SATs, again flagging up if somebody's saturation is below 93% to consider referral, and we are lucky enough with the All Wales Oxygen group that an All Wales Oxygen referral form has been developed. Next slide, please. So going on just to more observations, really. One of the key things that was introduced into this form was something called the Q-risk 3. There's now a Q-risk 4. In hindsight, the reason we put this in was for many reasons, but we're all talking about the cardiorespiratory risk and the matrix at the moment, and felt it was really important to highlight that. But within this form, it didn't auto-populate things like blood pressure, height or weight, sometimes that was already within the system. So this is something that we are currently tweaking. There is also a Q-risk 4 out there now, which specifically looks at COPD. So again, we're going to make some amendments within the new version, and I think before we send the new template out across Wales, we're going to put together through the network a educational package which will go through the template, the reasons for completion of the template, and also highlights the reasons why we need to link in and complete the Q-risk. So, and then going on, it talks about the key things, inhaler technique, your vaccinations, and also talks and highlights any sort of exacerbations or hospital admissions. So really red flags and categorises the risk associated with our COPD population. Next slide, please. It also goes on to phenotyping, whether it's phenotype 1, 2 or 3, and also indicates whether patients require dry powder inhalers or SABAs, and obviously we're heading towards more dry powder inhalers in relation to the carbon agenda, but at the end of the day, it's what the patient can use is what we prescribe and what they need to be prescribed, and also to ensure that all patients are given a COPD self-management plan. And there's two ways of doing that. You know, we've all got written self-management plans that we can give patients without access to IT or digital technology, but we've also got the All Wales COPD Hub with the self-management plan that people can access through their phone, that I hope we're all promoting through our COPD reviews currently. But again, this link goes directly to that, and then you can give the patient the information to be able to self-manage. Next slide, please. Okay, so there's many benefits of standardizing and structuring a template. It makes the consultation easier and the flow. You can report the symptoms, the physical exam findings, and care management for multiple conditions. You can track your medication, you can track symptoms, whether there's improvements, whether there's deteriorations, and you can also track sort of any interventions that you are considering or you've taken on board. And of course, this information will be then as part of the NRAP data that we as a network will be able to look at and review to see what practices may need more support with and intervention. Key interventions then as part of the guidelines are followed and documented as part of an All Wales template. It ensures coordination and communication between healthcare providers. So on the new template, we're currently working on a direct referral into secondary care, which would auto-populate and go direct. So again, reducing the time for completion of referrals. I know referrals into secondary care are different across different GP practices. Some GPNs can complete them, some AMPs, some GPs. So again, it will work according to what systems we've got within our practices. And like I said, it provides a really good audit tool to evaluate care and outcomes. Next slide. So as I mentioned previously, there's lots of issues with the current templates. But there's been quite a few challenges in relation to the practices that we've currently used as the pilot. So as you may or may not be aware, there was changes over this time in relation to vision converting to EMIS. So we had 2 training programs, we had 2 versions of the template. And also we had some practice changes from vision to EMIS, so it involved us maybe going back into those practices and working really closely with them in relation to supporting them with the new EMIS system, but also the new template that we were embedding. As I said, the hyperlinks within the system are different depending on each health board. As a network, again, we're trying to unify referral forms so that it makes the process easier, but within each health board, they will have their own hyperlinks, which will be different. So this caused some challenges when we originally set up. Within ABHB, we had a few managed practices as part of our pilot, and these reverted to independent practice, and then they came back to managed practice. So again, change in system, change in management, changed in, you know, your clinicians again, so a lot of education and training. And I think we've got to be mindful as well that when we change or upload or do something different with templates, it's really important that our admin, our navigators are aware of the reasons and why we need to code patients. So as part of the rollout of the education platform that we're going to deliver, then we'll be encouraging clinicians and non-clinicians to attend those events. Obviously with any sort of change, we can have, like I said, staff changes, our general practice nurses or our specialist nurses leaving those practices and new GPNs joining, and there's financial implications as well in relation to any new system. But luckily with the support of ACT and the support of AZ and Tritech, who supported us with the audit, we've been able to do the tweaks and the changes and develop what we need to ensure we've got a robust template to roll out. Next slide, please. So as Keir had already highlighted within the map, we've had several organisations, so health boards included, and Nairon Bevan Health Board sort of leaded the way, and Hywel Dda and Swansea came on a little bit later throughout the project. So 21 practices were installed and 16 practices were actively engaged. Next slide. So in relation to data collection, as I mentioned, Gareth from Tritech and the team have been fundamental in supporting us with some data extraction, and it also highlights then where we need to do some more work. So again, it's been very difficult to collect data from a national perspective because of access to clinical systems and GDPR, but within the practices we did manage to pull off some data, and we collected data. That the set was that we were our aim was to collect 500 patients, but we increased that and managed to do 634, and 572 of these having then a confirmed diagnosis. Next slide, please. So apologies for this slide, but it just gives you a bit of an overview of what type of data can be pulled off. So as I've mentioned, you know, your smoking referrals, whether they never smoked, ex-smoked. As you can see, again, 8 patients were not recorded. So it's really important that, you know, when we use templates, that we try and complete all the areas for accurate audit data. And it goes on then to advice referral in patients which have declined. The pulmonary rehab. Again, we're working with the pulmonary rehab group to see if we can improve this outcome further. I think what we have found across Wales is many health boards haven't got pulmonary rehab services at the moment, and some health boards have got long waits. Therefore, you know, the referrals into rehab are maybe not as they should be, and we would encourage people to refer, otherwise we can't capture those patients who need rehab and who haven't got access to service currently. Looking at your flu, pneumonia and your COVID, and looking at medicines optimised. Sort of all those 634 reviews, 290 patients had their medicines optimised. Now, when I talked about the Q risk, a large proportion didn't have their Q risk recorded, but on hindsight, on reflection, on feedback, it was because the Q risk isn't sometimes not familiar within the respiratory assessment and haven't been used before, or the difficulties of auto-populating it. So this is a piece of work that we will need to work on in relation to the rollout of the new template. Next slide, please. So again, recording a smoke cessation and the importance of referring our patients on. Next slide. And next slide. So as you can see, the data really looks down and looks deeper into what is needed. There's a little bit of data that we've sort of identified that, again, we need to work on, but we're currently working on this, and hopefully the next version will have more data that we'll be able to pull off. Next slide, please. Next slide. Okay, so as I said, we're in a position now where we have had both patient feedback, we've had verbal feedback, and we also sent out a staff feedback questionnaire to all staff who've been involved in the template. And that's given us some really constructive feedback into how we can assess patients, you know, the time that was spent, what would make things easier, what would simplify things, what would take less time. And a lot of it is about auto-population, auto-populating referral forms, and sometimes in relation to our assessment, the flow of assessment in relation to ease. We secured a grant from AZ to start the template, and we've also secured the grant from AZ to make the amendments of the template. And VIPC, which supported us with the original version, is going to be involved in beautifying the final version. Once the final version is complete, which should be complete in the next month, then the version will be taken to the network to review and make sure that everything that everybody's discussed as a network and external is included. And then the plan is to conduct something a little bit like what we're doing today in relation to webinars, producing an educational package to ensure that we can roll this out across Wales so that everybody's using a unified data set for our COPD reviews. And then this will give us some really lovely data that we can work on and use, and hopefully we can see some vast improvements in our NRAP data, which at the moment doesn't look, it looks quite poor, but again, you know, I think the majority of that is due to inaccurate coding. We're also in discussion at the moment with the network and AZ about a collaborative working project very similar to this in relation to asthma, and this is something that we've taken on board because, again, of feedback from staff, and like I said, we developed a paper template for asthma reviews that we use as part of our educational package within AB, but this is something that we would like to be active across Wales as an electronic version, and hopefully, you know, integrated within EMIS. And then the last step, really, which we've already done, is we've spoke at the Welsh Thoracic Society, we've spoke obviously at webinars and conferences, and we've got a nursing conference in June that I'd like to encourage you all to attend, because we've got a jam-packed agenda, and there's also an ERS abstract submission, which I'll let Kia talk about for the next slide.
I'm not sure whether Kia's back. He put a message in the chat saying he had to pop out.
That's absolutely fine. If we go to the next slide. So Kia and a few others have kindly put together an abstract, and this is the abstract that has been complete and has been sent to ERS. So hopefully one of us will be able to present at the ERS this year. We will also be looking at, with Kia support, publication. So publication of the project and some of the data and some of the findings, and obviously, you know, producing a publication later on down the line when we can see the benefits for yourselves as healthcare professionals, but more importantly, the benefits for our patients. Next slide, please. So that's the end of the presentation. Thank you so much for listening, and I'm open now to any questions that anybody might have.
Okay, so just before we move on to that, thank you, Natalie and Kia when he comes back. But thank you for rising to the challenge, Natalie, when Kia wasn't here. So now we have some time for the questions. So if I know I could see some questions were going into the chat while you were speaking, Natalie. So if there's anybody want to raise the hand to ask a question, or we can look in the chat and we'll work through as many as possible. Okay. Sorry, Shaima? Sorry if that's not how you pronounce it. I'd like to go ahead.
Hi, yes, thank you. I just want to know, how do I get hold of this template? Because I can't find it on EMIS.
Okay, so the template in the current version is only available in the pilot practices. So what we're currently doing is working on the amendments, and then the plan will be is that we will do a webinar and an educational package, a little bit like we've got today, and then we will be able to distribute the templates out across Wales. So only the practices which are involved in the pilot have currently got that template in situ. Is that okay?
Yeah, that's great. When do you think you're going to be getting it more
So
Wales-wide?
That's okay. So we're hoping that the final amendments will be done within the next month. It will then need to go back to the network for review, and then I'm hoping our plan was sort of May, June, wasn't it, Andrea, that we would start looking at sending it out across Wales and ensuring that the webinars and everything are set up. So I would say within the next 2 to 3 months.
Yeah, so I'd just like to come in there. So it's part, as Natalie said, as the network's work plan. It's one of our priorities, the COPE template and the asthma template. However, we've only just had our priorities confirmed this week, and it was not all of them were in there, but this particular one was. So we are going ahead with it. Hopefully the end of Q1 they'll be out, but if not Q2. But I have taken details of your name, and we can obviously email you as soon as we know further. But yeah, it'll be literally start working on it now, and then we got our next meeting next week. So
yeah, thank you very much.
Helps.
Yeah,
you're welcome.
Thank you.
Carry on. Yep, sorry.
Carrie-Anne, are you on mute? I'm not sure. There's no sound at all at the moment.
Will we look at the chat while we were Carrie-Anne sorting that out?
If there are any questions that you don't think we've answered today, or if there's any further questions, then please, contact me through the network, and we'll be able to answer them. But we'll go through the chat bar now and have a little look to see what questions are currently there. Carrie-Anne, have you managed to get?
No. Maybe let's try someone else. Lynn Edwards asked a question. Lynn, are you here? Do you want to say your question out loud, maybe?
Oh gosh, I wasn't expecting that. Hi, I'm only here from a vaccination perspective because I'm matron for immunisations in Swansea Bay, and it was really just because obviously the JCVI have made a recommendation about our expanding RSV programme for people with respiratory conditions. So I can see vaccinations on the template, which is brilliant, but how easy is it to amend when new things come into the programme?
Yeah, so we will be able to amend the template, but as you're probably aware, with any amendment, there is a substantial cost. And, when it comes to all Wales templates, it's really difficult because you've got to change the whole template, the whole system, haven't you? So it can be done. But it will probably be, and especially if there's any significant urgent changes that we need to add in relation to guidelines, that can be done obviously quite quickly. So Lynn, I can say that it can be done, but it may take a little bit of time, and it would depend on funding. But, if you want to link in with me again to make any suggestions regarding the vaccination part of the template, be more than welcome to any sort of guidance on that, because we're doing those changes now.
Brilliant, thanks very much.
Thank you. And we have Jane Chivers. Is issue of COPD rescue pack on the template?
Is the COPD rescue pack on the templates? The self-management, so each health board has got a COPD self-management pack. It depends on the health board. We've got the self-management app on there, which gives advice and treatment and things, but we don't obviously encourage everybody to have their own stock of emergency medication. So it does depend on the practice when it comes to that, but there will be sort of all Wales guidance and data embedded within the template, if that answers the question.
Oh, thank you, Natalie. Jane, did you want to add to the question?
Yeah, it's just we're encouraged to code if we issue a COPD rescue pack. So it would be useful if it was on the template. So we follow the EOLIAS guidelines, which say if they've got more than 2 exacerbations, you look at issuing a rescue pack, and we're supposed to be coding that back in EMIS. So I think if that was on the template, that would be really useful.
That's no problem, Jane. I will double check if that was in the feedback on the comments, but if not, I'll make sure we take a note of that to include it. Thank you, Jane.
Thank you.
And we have a question from Gareth Hutchinson. He has no microphone at the moment, and his question is, how long was needed for each appointment using the new template?
Okay, so again, what we did notice is that it was variable, and I think there was a little bit more time spent on this template than I'm hoping the new version is going to, because of the auto population and for the flow. And I'm very mindful that, again, within each practice, general practice nurses, GPs, whatever, get different amounts of time sometimes, which vary from 10 minutes to 20 minutes, and then obviously a little bit longer if you're undertaking any significant testing, spirometry, etc. So the aim of the new template, and what the feedback has been, is that we need to try and get a template within 10 minutes. So that's our sort of aim, but people were taking from 10 to 20 minutes to complete. But again, it depends on their background, their competence, their skills, and obviously the patient in front of you, because every patient is different, and different patients take in the education, the information, and what is being told a little bit quicker than maybe others. So yeah, it was variable across the patient reviews.
Thank you very much. And we have a question from Rianne Jones. Rianne, did you want to ask it live if you're still around? Or I can read it out loud. And the addition of a COPD rescue pack review of appropriateness of rescue pack be included in the template.
So I think Jane have already highlighted that within her question. So we will make sure that is embedded. I think that's a key thing. And we'll have to look at maybe the suggestion of having an All Wales rescue pack sheet or something. That's something I'll take back to the network.
Okay. And Carrie-Anne, I'm so sorry there were issues with the microphone. Did you manage to get it sorted, or would you like
Can you hear me now?
Yes.
Oh, great. Sorry, I have written it there as well. Sorry, this sounds really fantastic, exciting, and it makes everything much more consistent through Wales, and it's brilliant. But I'm really jealous. I'm saying that in a light-hearted way, but really I am quite jealous, because when I work in primary care, I no longer can refer someone for spirometry, so I can no longer diagnose someone with COPD. It could be at least 12 months waiting for secondary care, so therefore I cannot refer to pulmonary rehab. And so sadly there's no equality across Wales, and we're going to have a problem in the future in this area with COPD. Do you know if any work's underway to address this and rebuild some consistent pathway regarding this very basic part of COPD management?
Yeah, so there's some work currently being undertaken in relation to the breathlessness pathway, but there needs to be a diagnostic pathway really within each health board. And I can give you an example of AB. Within COVID, we set up a spirometry hub through primary care, which was supported by primary care and also the primary care respiratory nursing service. And that was undertaken over 18 months, and then due to finance and different changes, then that was pulled. But what we'd used that spirometry hub for was for an education platform. So our general practice nurses, healthcare support workers came in, were invited into the hub to maintain their skills, their ARTP accreditation and their competencies. And then when we went back into practices, obviously those general practice nurses, etc., were able to then to continue with the spirometry, which is being undertaken. And for new staff, they would come to our academy to have the spirometry training. And we have restarted that spirometry hub more recently. So I would say 70% of our practices still perform spirometry within the practice, and 30% for different reasons refer into our spirometry hub. So I know we do it, I think Swansea do it, and there's a couple of other, but that this concern or this issue is raised to Kerry Ann quite frequently through conversations in relation to spirometry. And spirometry sits with health boards, so it's the health board's decision of the way that they support and perform spirometry in practice. But with the breathlessness work currently being undertaken within AB, Swansea and Cardiff, we're hoping within the next year that will be rolled out across Wales. So that will support you with some of that elements, but it's quite a selective patients who are going to be able to go through that pathway. But as part of ours, they can refer in for spirometry first.
Okay, thank you.
Okay, is that all the questions, Christina?
I can't see any more in the chat. There was one more question asking about the slides, whether we're able to share the slides. I just wanted to check with you, Natalie.
I can't see there being an issue in relation to sharing the slides, because we shared the slides at the Welsh Thoracic Society meeting. So yeah, and we will confirm that with Kia, because I'm just mindful the first part of the presentation was his work. But we'll confirm it first, and if Kia is happy, then we can share slides.
I think
if required.
Yeah, perhaps if we link it in with the webinar on the website, Christina, and people can access it from there, is that possible? Or put it in the chat once we've had agreement off Kia.
Yeah, we usually add it on the website. And
brilliant.
We can put it in the chat as well. Yeah. No
okay, thank you. So coming to the end of the session now, so I'd like to say a big thank you, Natalie and Kia. You can thank him on our behalf, Natalie, for sharing their time and expertise with us today. Thank you as well, everyone, for joining us and your contribution. Your questions and engagement really does make a difference to the sessions and make them really worthwhile. The recording will be available shortly on the Respiratory Matters Teams channel and the network website. Before we finish, just a couple of final points. We will be sharing a short survey in the chat, and we use this help us just to continually improve and shape our future webinars. And we want to keep them valuable and interesting and relevant. So we'd be really grateful if you could take a few minutes to complete the survey. Also, if you do have any suggestions of webinars you'd like to see in the future from the Respiratory Network, please put your suggestions in the chat as well. I'd just like to flag our next Respiratory Matters webinar in May. It will focus on lung cancer screening in Wales, and it'll be presented by Dr. Sinan Eccles. The registration link is in the chat, so please register and share with your colleagues. Just a reminder, if you haven't already, put your name in the chat if you want a certificate for your attendance. And that's it. Thank you once again for taking the time for joining us today, and enjoy the rest of your day. Thank you. Bye.